Okay, folks, thank you so much for being here. My name is Megan Bramlett. I'm a student at the College of Public Health. I'm here for technical assistance. So if you have any issues with tech, shoot me a message. I'm also going to be fielding your questions. So if you have any questions for any of the speakers, please go ahead and put those in the chat. And as time allows, I will read them as we come to the end of the presentation. I did mention this before, but do please make sure that you are muted throughout the presentation, unless we're speaking, of course. Thank you all so much for being here. We've got a fantastic panel today. We've got Dr. Fazal Khan, who's an associate professor at the University of Georgia School of Law. He teaches and focuses on health law and policy, public health law, bioethics, and international products liability. We have Dr. Ani Satz, professor of law at the Emory University School of Law, focusing on health law, disability law, law and philosophy, animal law, and torts. And Stacy Kirschner, associate director of the Center for Law, Health and Society at Georgia State University, and also a professor of public health law. And last but not least, Greg Sunshine, works for the Centers for Disease Control and Prevention as a public health analyst at the Public Health Law Program. Thank you, speakers, for being with us today. I'm going to go ahead and mute myself. You're welcome to introduce yourselves further, and I will turn it over to you now.
Thank you, Megan, for that. And thank you, Dr. Grace Bagwell-Adams, for inviting me to convene what I call a superheroes panel of public health law experts that we have here in the state of Georgia. And I'm really kind of interested in kind of hearing their perspectives and the perspectives of the audience members. So please feel free to ask us any questions after our opening comments. So I asked my fellow panelists this kind of general question. Can you address like one or two aspects or issues related to public health law that you seen to be really vital in shaping the government's response at the local, state, or federal level in relation to the pandemic? And so posing that question to myself, and I'll just give you my initial thoughts, what really struck me was the boom in telehealth and telemedicine. So going back to the dark ages when I was in medical school, this is like the mid 1990s, late 1990s, telehealth was on the verge. Everyone was excited because the basics of the technology haven't changed that much, right? You're just using audio-visual communication means across the network to communicate across a distance to a remote location, right? So the patient and doctor or provider and doctor are at a distance. But for whatever reasons, we never really saw telehealth take off prior to COVID. So in 2019, the overall telehealth industry was around $3 billion, right? In kind of total revenue. So $3 billion, okay, that's a lot of money, but compared to the overall healthcare industry, which is $3.8 trillion, it's a drop in the bucket, right? And there's kind of some untapped potential there. So fast forward to COVID, and the public health emergency is declared at both the federal and state levels, and also by the WHO. At the national level through CMS, they waived a lot of their restrictions on using telehealth that really, you can see in retrospect, clearly that kind of hindered the uptake of this technology and really did away with some of the lingering concerns about, patient acceptability of this means of this delivery of service, providers' ability to also buy into kind of telehealth. But all those doubts kind of went away early on. So we saw this exponential growth in telehealth following the restrictions of certain waivers. And some of them include waivers on geographic site. So you had to be in a rural area or in a designated underserved area in order to be able to reimburse, say, under Medicare rules. And you had to go to what was called originating site, which meant that you couldn't just pick up your phone and do a telehealth visits using whatever apps are on your phone. You'd have to physically go to an originating site that's pre-approved and then use your audiovisual equipment to talk to a doctor, consult a doctor at a distance. So not very convenient. So doing away with originating site restrictions, geographic site restrictions, and also CMS, I think, had a very important waiver, which was allowing for out-of-state practice of medicine. So as long as you're licensed in any one state under Medicare, you could bill in another state, so long as that state also allowed for out-of-state practice. And many states did during the emergency. So think of New York, an early hotspot. They were inundated and they were pretty stretched thin in terms of the healthcare capacity. So early on, the governor Cuomo, Governor Cuomo, kind of waived all restrictions on out-of-state doctors practicing in New York. So telehealth services can be provided very easy through kind of Medicare, and a lot of other private insurers followed suit. Now the question is, after the emergency, which of these temporary waivers should become permanent? And so in the summer of 2020, the Senate Health Committee had a panel discussion on exactly this issue. What have we learned from the early months of COVID, and which restrictions should we keep, modify, or reverse? In terms of keeping permanent, there seemed to be broad bipartisan consensus on keeping permanent, kind of not requiring the originating site thing where you had to go physically to another location. So that makes it a lot more convenient for patient uptake. And also not to have the geographic site restrictions. So now you can access telehealth services more broadly if you're in an urban, suburban, ex-urban area. But some of the other restrictions, such as allowing, say, HIPAA waivers. So, patients could use like WhatsApp, FaceTime, Skype, these common consumer, messaging apps that weren't HIPAA compliant. That's going to be reversed. And that's not, I think, a really big barrier, because a lot of the vendors have gone back already and kind of built in that HIPAA compliance going forward. But other issues obviously are lack of infrastructure. We know at the federal level, there's still a lot going on in terms of whether they will pass that bill. And that issue, in terms of what defines infrastructure, there's bipartisan consensus. That includes broadband 5G, especially for rural areas. And we've seen what a challenge it's been during COVID, but even prior to COVID, for individuals living in these areas to access, basic health services. Just focusing on mental health services, as many of you know, Georgia lags really far behind in terms of those types of resources. As of 2018, I saw a study that 76 out of 159 counties in Georgia had no licensed psychologist, and 52 counties have no licensed social worker. And just last week, I saw my primary care physician here in Athens, and I asked him about kind of, if you had to refer a patient for psych, he's like, well, it'll take at least 5 to 7 months. And I found that shocking. And so what we found with telehealth, there is a rapid uptake and patients and services being provided by telehealth. And even after, a lot of states have opened up and we've seen kind of telehealth usage kind of come down for most types of visits, we've seen a kind of sustained increase in mental health services. So what that tells me is that, one, we might get more compliance. Patients seem to like that type of communication. And two, it's increasing access to care in an area that I think has been, underserved for a very, very long time. So my suggestion going forward, when it comes to, in addition to the obvious, I think there's consensus that, keep permanent the originating site restrictions, take those out, take out the geographic site restrictions. But when it comes to practicing across state lines, increasing capacity, I'm working on a current research project where I argue that the federal government should look into providing, say, a Medicaid bonus, using their spending power to incentivize states to change their laws to allow for more liberal practice across state lines, especially in areas such as mental health and other types of services that a lot of states simply don't have the capacity. And, it would be kind of more equitable distribution of resources and kind of cut down these wait times. As many people know, like COVID has really stressed our system in a lot of different ways. And so, especially when it comes to making this capacity greater, I would argue that should be, something that legislators should definitely think about, making telehealth a lot more accessible across state lines, particularly in the area of mental health. And I'll stop there with my initial comments and pass the baton to Stacie.
Thank you. Again, I'm Stacy Kirschner. I'm the Associate Director for the Center for Law, Health, and Society at Georgia State. And while Professor Khan spoke about potential opportunities in telehealth that have arisen during COVID that could continue post-COVID, I'm going to actually speak on potential threats that have arisen during COVID and that could constrain public health response to future emergencies or even regular public health operations. So for context, there must be legal authority for everything that public health does. While public health or even health isn't mentioned in the Constitution, government has to derive its powers from somewhere in order to act. At the federal level, the government derives this authority from the Commerce Clause and the power to tax and spend. At the state level, authority for public health has been derived from the 10th Amendment, which reserves powers not otherwise delegated to the states. The term police powers doesn't literally just mean the police. Police powers include anything protecting the health, safety, and welfare in the state. States may also delegate their powers to the local level. The Supreme Court affirmed the government's public health authority in Jacobson versus Massachusetts, which you've probably heard mentioned several times in the news over the past year. In 1902, there was an outbreak of smallpox. Cases had increased exponentially, and under the authority of a Massachusetts state statute, the Cambridge Board of Health voted to require vaccination of any resident who hadn't been vaccinated since about 5 years earlier. The Reverend Jacobson refused the vaccination, was convicted and fined $5, which was about $120 in today's currency. He refused to pay the fine, arguing that the law was constitutional, but the case went up to the Supreme Court, and the Supreme Court upheld the mandatory vaccination law, stating there are manifold restraints to which every person is necessarily subject for the common good. So the court set up this balancing test with individual liberties on one side and the public good on the other, and asked us to balance and see what would tip the scales. And in this case, vaccination was needed in order to address the smallpox outbreak, and the community, the public good was more important than individual liberties in this case. So even though this case is over a century old, it has provided constitutional support for a spectrum of contemporary public health laws, not just vaccines. And over the last few months, this case has come under scrutiny by the media and the courts. This is one of several threats to public health legal authority that could have lasting effects and go beyond this pandemic, not just for future emergencies, but as I said earlier, also for regular public health activities. And I'm going to outline a few of these threats. I know some of you, I saw attendees who actually attended a panel that we hosted last week at Georgia State. And so some of this information will sound like a little bit of a recap for you, but I want to give credit to those who are doing research in this field that I'm building on. And that is Lindsay Wiley, Wendy Parmet, Michelle Mello, James Hodge, Layla Barraza, and Jill Kruger. So first, as in Jacobson, courts have traditionally been deferential to public health. It's not for the court generally to decide which theory is appropriate to prevent disease. Deference will usually be provided to the state, to the public health authorities, unless the intervention has no real or substantial relation to the outcome or it invades rights. And there have been a lot of cases challenging public health actions during COVID. Courts have upheld businesses and school closures, for example, but one area where we see courts pulling back on this deference is related to cases arguing infringement on freedom of religion. The court heard several cases last year challenging state and local restrictions on gatherings that impacted churches, for instance. And they tightened their review, even review of seemingly neutral laws that impacted religious gatherings. And it allowed activities to move forward that public health had restricted due to the risk of disease transmission. With vaccine mandates, we've seen a mix of cases with some courts upholding vaccine mandates for universities, healthcare, and other entities, and others overturning when religious exemptions haven't been offered. So the concern beyond COVID is what will happen to K through 12 vaccinations. So, 44 states and DC have either religious or philosophical exemptions, but several states have moved away from having religious exemptions and only have medical exemptions for school children in K through 12 programs. And that's really been a trend after the recent measles outbreak. And the American Academy of Pediatrics has actually supported this move. Challenges to these state vaccine mandates arguing that religious exemptions should be offered have previously not been successful, but the current trend jeopardizes this and potentially could impact our K through 12 vaccinations. Another area where there are concerns is restricting public health authority. So the Network for Public Health Law and NACHO released a report over the summer examining this. They found that every state had at least one bill that was introduced that would prohibit, restrict, or shift the exercise of certain types of public health authority. And 20 states had actually enacted such a law. So many states limited liability from businesses for spread of COVID-19. My colleague Tim Litton has done some extensive research on this, and he argues that the threat of liability is actually a good way to ensure that businesses comply with public health guidance to reduce potential spread of COVID-19 through measures like requiring masks or social distancing, et cetera. And the actual risk to businesses of being found liable for spread of COVID is incredibly low if businesses have followed public health recommendations, because it's really difficult to demonstrate causation that you actually caught COVID in a particular area. And if businesses have done what's reasonable, then they won't be found liable. But eliminating liability also eliminates the incentive for businesses to behave responsibly, and that's endangering public health. Other legislative efforts have sought to limit the governor's emergency powers by shortening the length of emergency orders without review by the legislature, limiting the governor's ability to act in certain arenas like restricting religious gatherings or closing business. One law was proposed in Georgia, but it didn't go anywhere last spring. And arguably, these proposed laws may be some political theater in some ways, but if something gets passed severely limiting a governor's ability to respond in an emergency, what happens when something more devastating than COVID comes along? Will an effective response be curtailed by these legal obstacles? One new state law ends the ability of public health to quarantine. This is not in Georgia, this is another state. Remember, isolation is the separation of a person who is ill from those who are not in order to prevent the spread of disease. Quarantine is the separation of someone who may have been exposed but isn't yet exhibiting symptoms, in order for that person to not spread the disease if they have gotten it, but they just aren't yet aware. Restricting quarantine has negative effects far outside of COVID. Quarantine is used to prevent the spread of other diseases as well, such as measles or tuberculosis. Not allowing quarantine could significantly endanger the public's health. The network report also examined state bans on mask mandates. And I know that Greg's going to talk a bit on this, so I won't spend too much time. But they also looked at restriction of requiring vaccination or proof of vaccination and restrictions on closing businesses. Some of these bans have been COVID specific, but not all of them have. So some of them could extend beyond COVID. Many of these state bans have negatively impacted the ability of local public health to respond. In some states where mask mandates have been banned, local outbreaks could have been stemmed by requiring masks, but local authorities' hands were tied. Some larger cities like Atlanta have challenged the state's authority on this, but many local governments just aren't in a position to do that. This restriction of the lower level of government by a higher level of government is called preemption. Preemption is not just a COVID concern. It's been used in other areas to restrict local government, sometimes successfully and sometimes not. For example, in tobacco with clean air, indoor air laws, or with trans fats in the area of nutrition and prevention of chronic diseases. Preemption as a concept is neutral. It isn't necessarily good or bad, but in some cases it makes sense for a higher level of government to act. In some cases, a lower jurisdiction tries something and then the state wants to adopt it across the board to have a set standard. For example, in driving, having a law that requires seatbelts in one city but not the next, or requiring hands-free driving in one city but not the next, would be difficult for drivers to follow. A statewide law makes more sense. Often the state is setting the floor, the minimum, and locals can act in stricter ways. But when the state restricts locals from taking action altogether, this can have detrimental public health effects. Before I turn over to my colleagues here on the panel, I want to touch very quickly on the federal government's public health actions. As I said earlier, the federal government finds its authority in the Commerce Clause and the power to tax and spend. Public health has tested the limits of this authority during COVID. For example, the eviction moratorium. Is the Public Health Services Act broad enough to include this type of activity? Generally, it's been more limited to quarantine and isolation of individuals coming into the country or crossing state borders. And this is what the Supreme Court found too in August in a case that it was decided against the eviction moratorium. Vaccination also hasn't traditionally been in the purview of the federal government, but it's finding ways to expand on this, mandating that healthcare workers in facilities that receive Medicare or Medicaid funds, something that's federal, is an example of using that power to tax and spend. Mandating masks on public transportation, such as airlines or MARTA, is tied to the Commerce Clause. So are these things legal? It's up to, as law students know, the answer is really, it depends. And so that's where I'll leave it for right now, but I look forward to your questions on these public health threats and things that we can do to avoid them and to continue public health response to emergencies and to general public health authority in the Q&A. Thank you.
Thanks, Stacie. That was great. Now I'll turn it over to Greg Sunshine.
Hey, happy to be here, everyone. So I'm Greg Sunshine. I am a public health analyst in the public health law program at CDC in the Center for State, Tribal, Local, and Territorial Support. So while I am an attorney at CDC, I am not an attorney for CDC. I do not work in the Office of General Counsel. I don't represent the agency. I don't provide legal advice to the agency on any agency operations. I don't provide legal advice to anyone, for that matter. I'm not technically a practicing attorney. I keep my license up to date because a lot of work went into getting that, but I do not use it. I am strictly someone who collects and analyzes laws and legal tools across jurisdictions and across time to measure the impact that they can have on public health outcomes. And specifically, my subject matter expertise is emergency response law and policy. So prior to COVID-19, I was doing all kinds of work on public health emergency response powers, analyzing gubernatorial hurricane response through executive orders, laws allowing for suspension of statutes and regulations that inhibit the response, examining new uses of public health emergency declarations for some atypical public health threats, and all of that kind of came in very useful, but all that other work came to a screeching halt when the pandemic started. And I focused specifically on the collection and analysis of COVID-19 mitigation measures and measuring their impact on our communities with epidemiologists and statisticians and all other kinds of economists, smart people at CDC who are much better with numbers than I am. But that systematic collection and analysis of laws and policies across time to measure their impact on public health is what we in the field refer to as legal epidemiology, seeing how law can be a tool to protect public health and safety. And so, one of the early things that started to happen during the COVID-19 pandemic, which was, certainly the first kind of public health law tool that came to mind when Dr. Khan asked his question about what were those one or two really important public health law tools in the pandemic. It was those emergency declarations that governors were issuing and the legal tools that they were putting into practice using those emergency declaration powers. And over time, and I'm talking about back to the 1950s, during the Cold War era, when states were passing these statutes, state legislatures were recognizing the need for the executive branch to have some specific time-limited powers to respond to emergencies that are affecting their communities, because legislatures just aren't equipped to make those immediate, efficient decisions to direct state resources to respond to an emergency. That's a tool better held by the executive branch. And so they delegated a lot of those powers to the executive branch upon the declaration of an emergency, as the legislature had defined in statutes. And in granting these powers to governors and sometimes to health officials or emergency management directors, legislatures would list out, specific tools and powers governors have. And oftentimes these lists were not exclusive lists. They would, include language that says something to the effect of, in order to address the emergency, the governor may take the following, may take all actions necessary to protect the health and safety of the community, including but not limited to, and they would list out certain things, which is really important to have that broad grant of authority and not anticipate that legislatures or anyone for that matter can really specifically predict the kind of legal tools we would need to respond to any variety of emergencies that are affecting our communities. But one of the specific tools that was granted to governors is kind of a broad tool. So they specifically granted to governors in 35 states the broad tool to suspend any statutes or regulations that inhibit a response. And I've long argued that this is the single most important public health law tool that exists. Because as I said, we cannot predict what the next threats are going to look like. We cannot predict what old threats will do in the future in different ways than they have done in the past. And the ways in which laws could inhibit or enhance our response are really unpredictable. So giving the executive officials the power to identify statutes and regulations that are inhibiting our immediate response to an emergency and the power to waive those is really the most vital tool that we can have. And this is a power that's expressly granted in statute in 35 states. Now, in 7 states, the power is limited to just regulation. So this broad waiver authority is only applicable to regulation. So if you want to expand scopes of practice, if they are articulated in regulation, that means 42 states can really waive those regulatory requirements to expand scopes of practice. If it's articulated in a statute, 35 states can broadly waive it. And this doesn't include more specific legal waiver powers for things like procurement rules, contracting, hiring, or specifically scopes of practice. I'm talking about this really powerful, broad grant of authority to suspend statutes and regulations that are inhibiting the response. And I'm happy to drop a plethora of links in the chat where you can see an interactive map of our legal analysis identifying these states, and you can actually just see the citations. Though that data is from 2017, though it tends to not change all that much, but I think it would be really important to revisit those powers in the coming year or so as legislatures are once again cracking open the books on emergency powers. But these were really, really vital tools in the early and ongoing days in response to the COVID-19 pandemic. I did just was not a disciplined search, but I just did a search we've collected over 15,000 executive orders issued by states, tribes, localities, and territories to respond to COVID-19. And I just did a quick search to see how many at least include the word suspend in a variety of contexts, and over 2,000, which is just like a shocking number. It really goes to the breadth and scope of the pandemic, that there are 2,000 executive orders. I'm pretty sure we would have found 2,000 emergency response executive orders for every threat prior to COVID-19. An example is we published an analysis on hurricane executive orders, and for just looking at Hurricane Katrina through, I believe, 2018 was our cutoff, and we only found, I think, like 230 executive for all hurricanes over that entire time period, that 13-year time period. 2,000 executive orders that use the word suspension, let alone the 15,000 we've collected. So we're talking about an unprecedented scale of a threat and an unprecedented use of public health emergency powers. And so in this wide scale of use of legal tools, we saw a wide variety of the use of the suspension power specifically. It really came into play in a lot of the ways that Dr. Khan already articulated in terms of telemedicine. For example, state limitations on individual practitioners' scopes of practice, on reimbursement for insurance, on insurance coverage, on facility licensure rules to enable telemedicine. Using these broad suspension powers to suspend statutes and regs in that state that would inhibit that, even for information sharing and collection. And then specifically outside of the telemedicine arena, just the treatment of individuals, cross-border licensure reciprocity, expanding scopes of practice for things from treatment purposes, triage, all the way to more recent events in carrying out vaccination activities. The suspension powers for healthcare operations are just really, really vital. A practical example is it could be a really necessary tool to be able to use alternate locations of treatment, alternate care sites, using facilities or just rooms in a hospital that aren't necessarily used in part of the licensure area for healthcare facilities. So suspension powers can enable this expansion of healthcare services. Government operations, as everyone knows, are dictated by the law, right? By statutes, by regulations. So things like being able to hold public meetings online required governors to suspend statutes and regulations. And the question was, do I, the governor, use this broad suspension power to change this law? Or do we just not have public meetings anymore because this law says they have to be in person? So to suspend the law that requires them to be in person enabled them to continue to carry out governmental operations. Election statutes and regulations to enable effective, efficient election tools, administrative deadlines for tax filings, school operations, all these things were really vital government resources that were enabled to be continued to be provided with minimal or at least as minimal as possible interruption because of this use of the suspension powers. And so the question then is, as these declarations have been ending, which of these changes in the law do we want to make permanent? Which, are we going to at least need to memorialize as, vital tools to use going forward for the next emergency? With the time I have left, I just want to briefly talk about, the second issue that came to mind, which was the use of the public health powers, the broad kind of mandate to protect public health and safety granted to health departments by legislatures was absolutely vital. And if I could, specifically focus on one tool, it was the ability to issue mask mandates. Certainly, as private citizens, no one wants to be made to do anything, but as members of a public health community, it's long been proven from, speed limits to seatbelt laws to smoking limitations that mandates are just necessary to make things work on a large enough scale to really move the needle in public health. And mask mandates were just a vital tool. And my team on the COVID-19 response had collected state-issued mask mandates coded down to the county level, because there's often county level specificity to which counties these state-issued mask mandates applied. When we worked with a number of epidemiologists and economists and statisticians to measure their impact, and found really huge impact on hospitalization growth rates after the implementation of mask mandates, huge impacts on incidence and death growth rates. So great impactful declines in growth rates, which are really exponential. The study that we published in Morbidity and Mortality Weekly Report showed a 1.1% decline in the daily growth rate after the implementation of a mask mandate. And at first blush, 1.1% isn't that large of a percent, but when you're talking about daily growth rates, it's exponential. It has a huge impact on the pandemic, and it was really one of the most vital tools. And we also looked at states who had implemented mask mandates and how that impacted rapid riser counties, so counties that experienced a rapid increase in incidence. And counties that had mask mandates were actually, counties in states with state-issued mask mandates were 43% less likely to become a rapid riser county. And that's just a really massive impact. And the vaccinations that we have right now that are being carried out across the country are really, really vital tools. But we can't forget that they are relatively new in the timeline of this pandemic. And for future pandemics and future public health threats, to be able to use these kinds of public health measures and tools before we have pharmaceutical interventions, these non-pharmaceutical interventions are really, really vital going forward while we wait for the technological advancements. Vital to protecting health and safety, vital to protecting the capacity of our healthcare system to be able to serve individuals, not just those individuals infected by the disease du jour of the time, but anyone who needs healthcare services, and really vital to the economy. We found in two analyses, one that's published and one that's going to be forthcoming soon, that it really was the threat of the illness and not the shutdown of states that really inhibited the response. The economic activity early in the response. And we've also found that those jurisdictions that actually had mask mandates in place when they reopened their economies performed better than those that did not have mask mandates in place. So it really just goes to articulate the vital importance of public health measures in protecting health and safety and protecting economic stability for our people. And I think I'm going to sneak in one very, very, very brief third item, which really is the important role that economic support plays as a public health measure. It's not quite as obvious as a legal tool as the other things that I described, but it's really necessary to be able to provide unemployment insurance to keep people from being kicked out of their homes because of through no fault of their own, to provide economic stimulus. These kinds of things make non-pharmaceutical interventions, public health measures, tolerable by the general public because it enables people to live their lives while they're having to endure a pandemic. And to be able to live your life while being able to endure a pandemic makes the interventions that are protecting your health and safety tolerable and makes them politically tolerable. And I think we can never really discount the vital tool that economic support plays in protecting health and safety. And so with that, I know I went a little bit over, but I'll pass it to Tom.
No, that was great stuff, Greg. And I think you did a great job as highlighting the importance of the work that you and the public health law program at CDC do really vital resources in showing the impact of different regulatory legal choices have in kind of real world health outcomes, right, at the population level. So really good stuff. Now I want to turn to my dear friend and colleague, Satz, who will provide us with kind of more insights on some of the vital aspects of public health law that kind of really emerged during the COVID pandemic. Ani?
Thank you so much, Fazal, and thanks for organizing this panel. Good morning, everyone. I'm going to give you a little bit to look at. As Fazal said, I am at Emory, and I wear a few hats there. Mostly, though, my work is in law and public health, and I am someone who, oops, I'm sorry, hang on one moment. There we go. And I run the policy. I'm the leader for the project on health law, policy, and ethics, and have been at Emory for a number of years working on health law and policy issues. What I want to talk to you about today is really, I think, a group of people that we have chosen to forget about in our attempt to move forward as a society from the pandemic. And that is individuals with disabilities, and I would add to this title slide, and those with chronic illness. We began the pandemic in a really hopeful way. Those of us who work in disability law were buoyed by the formal statements that came from the federal government about all the preparedness that was in place post Katrina, where we saw individuals with disabilities dying, waiting for help. We had a lot of formal statements from Health and Human Services about commitment to our civil rights laws, to the dignity of every person, to the fact that persons with disabilities should not be denied medical care on the basis of judgments about their quality of life or their worth. This is not advancing. Hang on one second. Sometimes I find that Zoom does not like to play very well with PowerPoint. Check this again. And we even saw statements about human subjects research, reminding us about protections. We saw statements from FEMA, and we saw statements about crisis standards of care that affirmed this idea that we need to remember that we have laws that protect individuals with disabilities, some of whom may have chronic illness. So I felt good. I think a lot of people felt good when we began the pandemic. We would be protecting individuals with disabilities and those with chronic illness. Unfortunately, where we were in 2020 is what you see here. We had a proliferation of actions filed with the Office of Civil Rights of Health and Human Services by disability advocacy groups in many states and Washington, D.C., alleging various acts of discrimination, including rationing schemes that came about through discriminatory crisis standards of care measures within hospitals, hospital visitor policies that prohibited people from having support people come to the hospital with them when they needed care, and in general, issues with availability of testing for individuals with disabilities. These complaints were brought under the Americans with Disabilities Act, the Rehabilitation Act, and the Patient Protection and Affordable Care Act. And as you can see from the slide, many of these have been resolved. So maybe, after we had this good start, we had sort of a dip in the protections that we hoped would be present. Maybe you would think, we've started to rebound in 2021, but I'm going to suggest that no, in fact, we have again dipped again in a moment. But in 2020, this is where we were. And again, we saw even post efforts after Katrina, individuals with disabilities dying at very high rates. And this is after over a decade of intensive planning for emergencies, be they natural disasters or other emergencies for individuals with disabilities. There were a couple studies that were done. I've shown you them here. In New York, the death rate in particular for individuals with intellectual disabilities was 2 times higher than for other groups. In Pennsylvania, it was almost 2 times higher. And we could say, well, and it's also believed to be underreported because there wasn't a lot of surveillance. And we might say to ourselves, well, you know, these things are unrelated from, you know, when we have a hurricane and we have emergency preparedness for individuals with disabilities. But it turns out they're really not, in the sense of how we think about disabilities. Just as people in Hurricane Katrina and in all of the recent fires we've had in California have died waiting for help, the same was essentially true for people who were individuals with disabilities living in group homes. When the government decided to fund various relief actions, group home staff were not considered essential workers. They lacked personal protective equipment. They lacked bonus pay. They relied on public transportation, which at the time was recognized by the CDC as a vector for transmission. These workers were going into group homes where individuals with developmental disabilities live, and they were bringing COVID with them. They also have very low wages. So when some of them quit, these facilities were severely understaffed, which resulted in lower quality of care and also the spread of COVID. So we could say, in a sense, these individuals were also dying waiting for help. It's still not advancing. Hang on 1 second. I come back out and come back in. And you can't see that. Hang on. Sorry about this. I do this every day. I don't have a problem, of course. We saw challenges in 2020 in all of these areas: accessibility, medical bias, public education. We went to remote learning. There were individuals with disabilities who essentially had no education for that entire time. Greg mentioned funding and how important that is. And I had a slide that I took out, I should have left in, which shows a significant decline moving forward for funding for disaster relief for FEMA and other organizations, when at exactly the moment when to address structural discrimination requires increase in funding, increase in things like the national stockpile, so that we have protective equipment when we need it, so that we're not rationing in ways that discriminate against individuals with disabilities, and so that we can provide protective equipment to home healthcare workers, et cetera. And so just as we need general increases in emergency planning, we're seeing a decrease. We also saw lack of enforcement of disability protections, and I've already talked about residential facilities. So in 2020, things did not look so great, although we did see some resolution when it came to the crisis standards of care that were being used by hospitals to deprioritize individuals with disabilities. We saw some improvements with those standards. We overall saw quite a dip from how we started the pandemic. And where are we now? I wish I could say things were looking up dramatically after the resolution of some of those complaints, but in fact, things are not looking very good for individuals with disabilities and those who have chronic illness as well, regardless of whether that arises to a disability. In fact, we know that there was a very high transmission rate, as I showed, among some populations of individuals with disabilities, and now we have on top of that long COVID. Long COVID affected those individuals in some instances, and in other instances affected people who were not previously individuals with disabilities. We're now recognizing long COVID through guidance from Health and Human Services and the Department of Justice as a condition that can be disabling. Where are we now? Well, we have waning mask mandates, which hour by hour, minute by minute, perhaps depending on what studies you believe, 5 seconds by 5 seconds endanger the individuals with disabilities who are immunocompromised. We see people banning mask mandates or lifting them. We have already seen the removal of masks from outdoor spaces, even crowded ones. It's not official CDC guidance, but that's happening everywhere. Also, we have uncertain vaccine mandates for all workers. We know that the federal government is trying to impose vaccine mandates for large employers, but there are a lot of people who would not be covered by those mandates. At the same time, because we have no vaccine for children under 12 years old, we have surging pediatric infections, and we have seen in several states the reimposition of crisis standards of care to ration care to children who are most likely to survive. And this includes care being rationed amongst patients who do not have COVID, but who have other potentially disabling conditions, who also need ventilators and ICU rooms. Just this morning, I heard a long report on NPR about the difficulty that individuals with chronic illness and disabilities are experiencing in accessing care that they've always had for their disabilities or chronic conditions. And a report that was just released in part with NPR shows that these individuals will have either further disabling events or other long-term impacts on their health. And the researchers of the study were actually surprised at how widespread this was already. And so, I hate to paint a bleak picture, but I kind of want to end on a provocative note, because as someone who works in this field and as someone who has people I care deeply about who are immunocompromised, I have to constantly ask myself, is a return to normal for most of us that we desperately want basically an entrenchment of discrimination for others? And as a society, how do we respond to that? I think there's a legal response, but there's also an ethical one. And I think that that's something with which we really need to grapple. Thank you.
Thank you, Anya. That's very thought-provoking. I know, Megan, you are collecting questions from the audience. Is that correct?
Yes, absolutely. I've gotten a couple.
Allow me the speaker's prerogative. I just want to have quick follow-up questions to all the panelists, and then can we turn to the audience Q&A?
I'm so sorry. My alarm was going off. I didn't catch that question.
Oh, so I was asking if I could use my speaker's prerogative to ask a quick follow-up questions to my fellow panelists before turning to the audience questions.
You may.
Okay, I will try to keep this brief because I know the audience has a lot of good questions. So Stacie, that was really interesting presentation, and what it got me thinking about is we heard a lot of disputes between, say, local school boards in Florida and Texas, and the dispute between the governor and the school boards. Unless there's a specific statute, I think that's what the school boards in Florida are relying upon, a Florida state statute. Is there anything local governments or local school boards can do when it comes to, say, imposing stricter mandates than, say, the governor would allow, or is preempting essentially?
Right. So it really depends state by state what is either allowed or not being addressed. So if there's nothing at the state level that says one way or the other, then local school boards should have that authority to be able to move forward and have mask mandates. There's nothing precluding them from doing that. However, if the state has acted in either way, like to say that all schools should have a mask mandate or all counties should have a mask mandate, then then that obviously applies to locals, and they shouldn't be going the other direction and banning masks or not requiring masks. And in the same breath, if states are banning mask mandates, then they have to ask themselves, like, do we take on the risk of defying this government, the state government statute, that violation of preemption that I was talking about, and you have to weigh the risk as a public health official, as a school official, to see, like, is it worth moving forward, to prevent illnesses amongst our school children, and to ensure, like as Anya was talking about, that all students have the ability to participate. There are several ADA lawsuits related to the ADA moving forward related to that for schools. So, you know, it might be that it's worth the risk and that local school districts should move forward with a mask mandate, require masks in their schools, and see, you know, does the state respond? Do they just sort of let it go, or do they, you know, file something against the local district? And that also, you know, might need to take into account what support the local jurisdiction has from their attorney. There's going to need to be some collaborative discussion there, you know, about what would happen, you know, should the state, you know, respond in a way that would be counterproductive to what the locals are trying to do. So it's definitely a risk, but it might be a risk that's worth taking.
Yeah, no, thank you for that. That's very helpful, my thinking. Greg, one question that popped in my mind after your presentation, talking about, you know, that kind of preemption. And says, you know, the federal government preempted state licensing laws for pharmacists specifically, allowing them to give COVID countermeasures. So very limited preemption, just, I think it was just for, you know, giving vaccines or kind of the testing, right? So you got your brain swab at the CVS and a little jab there as well. But could you anticipate at any point the feasibility legally and politically of a national licensing scheme for providers to address some of the capacity issues, which, you know, that have obviously arisen during COVID?
So to the first point about the waiver of the licensing, the expansion of the scopes of practice by way of the Public Readiness and Emergency Preparedness Act, or the PrEP Act. And actually, I should have said this even before I said those words. Reiterating again that I'm not an attorney for the federal government. This is all very much the Office of General Counsel that handles PrEP Act issues, not even actually CDC's for the most part. The Assistant Secretary for Preparedness and Response is the office that handles PrEP Act issues. But I do want to point out, I'm in no way providing legal advice. I'm just telling you about what's on a webpage, that there have actually been the use of the PrEP Act, not just for pharmacists, but a wide number of practitioners. Back in March, they expanded scopes of practice to administer the COVID-19 vaccine to a large number of practitioners, including veterinarians and podiatrists through the use of the PrEP Act. And then more recently, in August, they actually expanded scopes of practice across the country using the PrEP Act for the administration of monoclonal antibodies. So not just, so it was just testing, then it was testing and vaccination. Now it's testing, vaccination, and administration of monoclonal antibodies. So to just give a good kind of like scope, and all this is publicly available on this really great website that I've just dropped in the chat. And they've got fact sheets and advisory opinions on the scope of that. Do I think it's is it legal? Probably it would be legally feasible. I mean, just in terms of, you know, knowing that there are other federal, you know, licensing requirements, you know, for facilities under the EPA and all kinds of things. The federal government licenses things nationally. It's just a thing the federal government has done in the past. So that's not totally outside the realm of possibility. Is it politically feasible? I think absolutely not. I think if I can speak outside of the practice of healthcare and the practice as a licensed, you know, professional in legal practice, I'm well aware that the vast majority, if not 100% of those licensure rules are the result of protectionist requirements to protect, you know, the lives and livelihoods of the practitioners within each individual state. And so I think there would be massive opposition to any kind of subjugation of the state by state regulation of the practice of medicine by the federal government, right? It's certainly something that we've seen in other healthcare practitioner areas, like the Nurse Licensure Compact, which is, you know, widely adopted. But I think it would require, you know, broad support from the practitioners and the trade groups that represent them, and be a thing for the states to adopt, like Nurse Licensure Practice Act, as opposed to something imposed by the federal. I just don't see that as a thing that would happen anytime soon.
Yeah, no, I concur kind through analysis, and that kind of relates to the current project I'm working on, so that's very helpful. So Ani, you know, that was kind of very kind of sobering presentation you gave, and you think about states like Idaho, Montana, parts of Alaska that invoked this crisis standards of care, you can see why the disabled community is very concerned, right, with the impact it has on them. I think you laid that out very well. So the question I ask, whenever a state invokes these crisis standard of cares, should there be almost essentially an automatic review by the federal government to make sure that this is not pretextual means to discriminate against the disabled community, and that there is a legitimate crisis that necessitates, this, essentially the scoring system of who they're going to treat, who they're not going to treat?
Yeah, so that's an interesting idea. I think that that would go part of the way to addressing the problem, but I think, one of the issues is just, a practical one, which is that we're not prepared, right? So when we face these types of decisions, in fact, a doctor, I won't identify the hospital, but in the state was telling me how, she was faced with the decision of putting in the ICU a patient who really could have been treated in the adult section, which was full. The patient was 18, knowing full well that if a younger patient came along, they would not have a bed. And so I think it's really, sometimes it is just a lack of understanding, and I think a federal check could help with that. Here are the laws, we have to follow them. But when it comes to rationing situations, even if we are rationing with an eye towards, who's first come, first serve, or who's going to survive, we are going to be disadvantaging people who may need care as a result of their disability in normal circumstances, who may be in and out of the ICU. And I don't think we've really addressed that lack of infrastructure and the lack of resources to sort of avoid some of those tough decisions. Fortunately, a lot of the crisis standards of care have moved past using quality of life as a measurement and or length of life, to some degree, statistic length of life, which can discriminate against individuals with disabilities. They're looking more towards immediate outcomes of survivability. But of course, there could be double jeopardy there too. If you have a disability that puts you at a lower survivability, and then on top of that, you have COVID, you still may not be the person allocated that bed. So in short, I think it could help, but I think there's a bigger resource issue at stake.
Thanks. So Megan, I'll turn it over to you and just make a quick housekeeping note. Ani has a class, so she might have to leave it several minutes early. So if there's any questions specifically directed to her, maybe address those first because she has to leave for her class before 11. Thanks.
Thank you. The first question is for Dr. Khan regarding the HIPAA compliant platforms for telehealth. That's something that's been found to be prohibitively expensive, especially for small practices, which in a lot of rural areas, small practices are the practices. Can you talk a little bit about how that might be regulated or somehow subsidized, or a way that it might be more accessible for those smaller folks?
Yeah, it's a great question. And that was one of the reasons that, telehealth never really took off. Like I said, it was like $3 billion industry 2019. But post-COVID, I looked at, it was a report from McKinsey that projected it'll be a $250 billion industry very shortly in the near term because it can scale up. And I think with that scaling up, there's massive investments coming from venture capital in Silicon Valley, that some of these barriers based on cost will fall, right? The same way we see kind of with Moore's law, kind of microchip processing power doubles every year or two. I think some of those barriers will fall as more investment comes in there. And already a lot of the large, say, cloud platforms such as Amazon Web Services, AWS, they have HIPAA compliance functionality built in. And so I was even had a conversation with a startup telehealth company that's here locally, and I just was asking them how they set it up for HIPAA compliance. And they said, well, that's already kind of built in. And so I do think there's these kind of structural resources available that can bring down the cost of that technology. So while it might be a barrier short term, I don't really see that lasting. And I think there's a workaround to ensure HIPAA compliance, but still making it available to even smaller practices on an affordable level.
That's great. Good news. Thank you. The next question is for Stacie. You talked about the sort of benefits and challenges of public health law. Can you go into a little bit of detail about maybe some challenges with the compliance and enforcement, since the law is just kind of that first step in actually making stuff happen?
Yeah, definitely. Thanks. I think that, there was in some sense with emergency preparedness over the last decade that the general public would, of course, want to comply in order to stem an outbreak, and that they would understand that it would be important to comply and with public health activities in order to end an outbreak. But that's not really what we've seen with COVID. We've seen that a significant portion of the population isn't, willing to comply, and that's not an outlier or extreme situation. That's a portion of the general public, and not just that they won't comply, but that many are actively fighting against public health interventions. And so we've seen that there's limited planning for the enforcement of the types of laws or the types of measures that we've tried to implement, and that neither law enforcement nor public health has the capacity to ensure that there's follow through on these important public health initiatives. And so what we've seen is that there's been sort of an attempt to shift the responsibility from government for enforcement to the private sector, whether it's businesses having to enforce mask mandates at their doors, whether it's schools having to, enforce mask mandates. And even before COVID, schools were sort of the enforcement mechanism for K-12 vaccination. That's where you submit your paperwork, for instance, when your child starts school. But also in places like transportation. I've done a bit of research in that area, and we were looking particularly at public transit during COVID, and the federal government mandated masks, but not all transit systems had the capacity for enforcing those mask mandates. And when passengers didn't comply, the bus drivers were the ones who had to deal with this. And I don't know how many of you have ridden MARTA, but often the bus driver is the only MARTA representative on the bus. And so the bus drivers were threatened. Some were even assaulted for asking passengers to wear masks or to disembark if they aren't going to wear masks. And just dealing with a non-compliant passenger can take time and cause routes to be delayed or schedules to not be met, which impacts other passengers who are trying to get to work or to their destinations on time. So that's kind of an option for enforcement that's really weak, and it puts people, ordinary members of the public, in a catch-22. So I think as far as, going forward, we really have to think as we're planning, not just for what laws and what public health initiatives need to be put in place, but how are we going to encourage compliance from the general public, and how are we going to handle enforcement for those that are non-compliant? I don't know that I have the answers to those questions, but it's something that needs to be thought out in advance as part of the planning and preparedness process.
That's great. Thank you. Dr. Satz, I have a question for you. Do you have something you'd like to say? Oh, you're muted.
I just wanted to briefly ask Stacie whether she thought trust in public health authorities played any role in this. It's interesting, you mentioned the private sector, but I think we've even gone beyond that. I also teach in the business area, and my business students say, really it's now almost come down to local, faith-based organizations reaching out to people, even more so than businesses. So I'm just curious if you had a sense of whether it was trust or lack of trust in public health authorities that was contributing to this.
Yeah, I definitely think that has come up and become a problem. And I think that part of it is a lack of communication and a lack of visibility. When public health does a really good job, we don't see it, right? When public health is working smoothly, things just happen as the default. We drink our fluoridated water. We get our vaccines. We don't, see public health, out in the open on a regular and daily basis. So the public hasn't had a chance to build up that trust in the way that they might unfortunately trust in other sources like that might be faulty, like the media or like internet, where, you know, not everything's, I know that's a surprise, not everything is truthful on the internet. But so I think that's part of the problem, is that public health generally is sort of behind the scenes. And so I think going forward, unfortunately, we're going to have to rebuild some trust that has been lost because of, you know, decisions by leadership in a variety of places, local, state, and federal. And then also, you know, not just build on it, but maintain it during the regular day-to-day public health activities to really showcase, you know, what public health does and how that improves the community's health in general when it's a non-emergency situation. So when it's an emergency, we're not trying to build that trust so quickly and to scramble for it, but that we actually have it in place.
And if I could just add to that, on top of all those issues, everything that Stacie said that I agree with, is just the fact of the nature of things that people in opposition to something tend to be loud and tend to be louder than people who are in support of the status quo, which in this instance has been, you know, a chronically underfunded, but unbelievably essential, vital public health system that we have. And so, the people don't go around, chanting in support of restaurant inspections, but boy, do we like them. Are they important, right? And so if there isn't, a groundswell of support of this, a large majority of the population to counter this very loud minority in opposition to public health measures, then decision makers and political leaders are going to continue to be swayed by the people that are emailing them. I was in a conversation with a state health department attorney talking about mask mandates, and a local superintendent of a school district said, we really need the state to put in a mask mandate. So I stopped being blamed for this because you can't believe how many Instagram messages I'm getting from people. But that's what's swaying school districts to lift mask mandates, is the amount of Instagram messages they're getting from their populace. And it makes perfect sense. You are in our democratic society. We want our political leaders to be swayed by their constituency. The only problem is the only vocal constituency, subject to certain exceptions, I think is evidenced by some of the activity by UGA staff and students recently. But the majority of the voices that are being heard are voices in opposition. And so unless we get the majority of people to start to speak up in support of public health, it doesn't really seem like anything is gonna change.
So we all need to start shouting our support a little bit louder. Is that a tip? That's great. Okay, Doctor, before you head out, Dr. Satz, I just had a quick question come in about if a person who maybe doesn't have very much power wanted to do their best to join with an organization and do some advocacy work, are there any organizations or measures you'd recommend on that end?
Yeah, so I would say, we all have power. We have power in numbers. There is a organization in Georgia for individuals with developmental disabilities that's extremely active doing policy work. And before I log off, I'll find that information and paste that in the chat box for you. There are other resources, so feel free to reach out to me directly. It's just asatz@emory.edu. Happy to provide other resources as well. I just, if I may, I have one quick question for Fazal about telehealth. I personally am super excited about telehealth. I've been thinking it should play a greater role for a long time. I think there are just so many reasons that in-person visits don't work, including for immunocompromised people who often pick up something worse than what they came in with. And so, I'm very excited about it, but I'm wondering if you had any thoughts about limits. One thing I heard was that, for some areas like pain management, we would need to have an initial face-to-face consultation. And that seems logical. But are there any other areas that you think might be more controversial for telehealth? than others, and where we might see a little bit more pushback.
Yes, and I think Greg addressed some of this or alluded to some of the challenges there. That, you know, you have organizations like the AMA, which is very much opposed to any sort of, you know, more liberalization of, say, cross-state licensing, and also expansion of scope of practice. So nurse practitioners, PAs, and other medical providers providing more of essentially primary care services. But I think going forward, the economics to do that is just irresistible, and that it takes too long, it's too expensive to have doctors be direct providers of primary care when the data shows that other providers can do it just as good. And in a lot of cases, there's higher levels of patient satisfaction. And I think primarily as a product of the amount of time they have to spend, whereas doctors' time is so precious, given the scarce supply, that, you know, they have to run in, run out, where you can spend more time talking to a nurse practitioner. And actually, in your presentation, made me think of the issue with, you know, the disabled community, that the thoughts before is like, well, it may, obviously it's more convenient, right? You have to deal with a lot of transportation issues for immunocompromised patients. Also, you have to be in a room with other people coughing on you. But there's always a sense that not being in person is a lower standard or a lower tier of care. But I don't think that necessarily holds after this kind of broad natural experiment of people using telehealth, and surveys show that there have been high levels of satisfaction. So I think going forward, we need to think about how to deliver care in a way that's more accommodating to all the communities out there. And the notion that telehealth somehow is a lesser version of care, I think thankfully that's gone away for most types of interactions. Obviously, some interactions have to be in person. And I do think common sense restrictions on, say, opioid prescribing without in-person visit will stay in place. Whereas for other types of, you know, prescribing, even for, you know, different types of, you know, psychiatric meds, that will probably be more relaxed rules in terms of being able to prescribe and not having to have in-person visits for, say, refills and refill checks.
I was just going to add something really quickly before I drop off, which is that I think this is a really exciting opportunity for people in health law and policy to think about what is appropriate and what isn't in this space, because it's here. I agree with you. It's here. I'm personally excited about it, but I think we do need to be thoughtful what the standards of care are going to be for different professions, because this is all emerging. So I'm really excited. Yeah. I'm really glad you're writing about it.
Yeah, and I'll briefly add, I think states do have legitimate political economy concerns with, you know, probably the largest segment of middle-class jobs, which are in healthcare in most places, right? You go to West Virginia, Kentucky, it's the hospitals that are kind of, you know, fueling a lot of these smaller communities. And if they're gone because Silicon Valley tries to do an Uber play, yeah, right, with kind of out-of-state workers, lower paid, you know, medical workers, and taking away those local economies, I think that's something states have a strong interest in, to try and have some control in limiting that type of competition.
Thank you. I've got another question here for Greg, and I think this might kind of tie in nicely with Tim's question that I will read next. As far as, you know, policy and scientific research sort of happen at different speeds. So when you look at your, when you present what you find, is it well received? Do you find people listen and respond? Can you speak to that some?
Yeah, you know, I guess I'm a masochist and don't really resist the urge to look at how Twitter is discussing our studies when they're published. And what it's really shown me is that, and then this really goes to what I was saying earlier about like a vocal minority versus like the majority of people that kind of understand and support public health science. Most people, you know, understand the importance of the studies and the findings, and understand, you know, there are limitations to these studies, and they're interested in the nature of how scientific studies are articulated. You know, some people get a little frustrated, but they're understanding that, you know, we can't publish a study said that like this causes X, right? But we can say it's associated with this, as anyone who does any kind of like statistical analysis understands, you can only control for so many things, and most of the time you can only show an association. So those, most people understand and appreciate like the limitations of what we can say based on, those kinds of causal relationships, and recognize the important like takeaways from the studies. But there are always people that aren't acting in good faith and are disingenuous. And there is, a lot of activity on Twitter from one particular social commentator who misconstrued the findings of our MWR. I mentioned, the point that, 1.1 percentage point change in daily growth rates, 1.1 isn't a large number. And this person, and this has been echoed ad nauseum since the study, these people will point to the table in our study and say, oh, well, CDC found that masks only had a 1% impact on cases and deaths, which isn't true. It had a 1% impact on daily growth rates, which is a massive impact, and really demonstrates the utility of these public health measures. And so, I think that we in public health, and to Tim's comment, have a responsibility to talk about, what went into our studies and be as transparent as possible, not just in terms of, how these things are ever evolving, but there has to be a lot of responsibility on us, the communicators, to be clear and to anticipate some of the disingenuous ways in which people misconstrue these scientific studies for their own agendas. And I think there's a lot to be said about this, emerging concept. It's not really emerging, but the concept of pre-bunking misinformation. We can really, if we try to, and take the time to anticipate the kind of misinformation and ways in which studies will be misconstrued, and pre-bunk them, and really articulate specifically in our studies as much as possible. But I think it is really important to focus, to not lose sight on, the broad popularity these public health measures have had, despite how vocal the minority of people who are opposed to them can be.
Thank you. The next question, I believe, is aimed at everyone. So this is from Tim Callahan from the Georgia Department of Public Health. A core element in established public health laws is that they have the evidence to provide foresight and support for their implementation based on supporting reasonable requirements. How can we address this lack of foundational evidence with policymakers and the general public for mandates in an emerging new disease outbreak epidemic? So I guess that was similar to the question before. Does anyone else want to speak to that?
Megan, I answered in the chat, but I'll sort of expand on that. And I said that, in emergency response, both lawyers and public health practitioners, emergency management, they have to move quickly on the information that is available. And a lot of times the decisions are being made before everything is known. I mean, just by the nature of an emergency. So they have to move forward without all the information or without the best information. But, they can't always afford to wait and wait for a 10-month study or a year to see what would be the most impactful way to move forward. So the key is really to be transparent about who is making the decisions. And I would say that collaborating at every level for that is key, so that it's not just one voice saying this is what I've decided, but it's we've come together as a team and all the minds in the room think this is the right way to move forward. Also, sharing how the decisions were made, what were the key facts that were included to make that decision, what do we know, and how did that play into what the decision is. And also, if we find out X, Y, or Z, we'll go in this other, we might change direction. Being upfront and clear that we're going on what we know right now, but that information is evolving, and it's really critical that we stay on top of new information, and we will be making those changes in order to keep the public as safe as possible, and to address the needs as they arise. And it's crisis lawyering, it's crisis public health, and it's not something that the general public usually understands. But if you're clear and transparent, you'll be able to have more people understand and accept what's being said. And I think that's really key.
Yeah, I echo everything Stacie just said. Like approximately, I think 10 years ago, is during the first Obama administration, I wrote an article entitled Ensuring Government Accountability During Public Health Emergencies, or during emergencies, it wasn't just public health. And that was in Harvard Law and Policy Review. And really what I was writing about is a reaction what I saw to the Obama administration codifying a lot of the emergency actions taken during the first two George W. Bush administrations, where after 9/11, after the anthrax attacks, obviously, and I was in DC at the time, both during 9/11 and the anthrax scare, and you could feel the palpable fear, like the real, I think, good faith fear that a lot of people had in the centers of government. And of course, Greg knows a lot about this. Larry Gostin and others got together and tried to update, modernize the state public health acts and drafted this model act, which within the public health law circles, there was a lot of, let's say vigorous debate with individuals like George Annis, Wendy Mariner, Wendy Parmet, taking a critical view saying, is this just an example of, say, 9/11 exceptionalism? And are we going too far? And are we maybe threatening, say, the bonds of trust within the social contract between government doing what's necessary and appropriate during emergencies versus using the emergency as a pretext to expand powers that maybe should be more open about and more transparent. And so, my suggestion was, even during emergencies, obviously you don't want to paralyze the government from taking necessary action, but everything should be recorded, everything should be transparent, and there should be that communication, and that in turn will kind of engender trust. Whereas if things are done and not explained adequately, and I think this goes along with Greg's point about pre-bunking, which is a great word. I never heard it before. I'm going to use it all the time now. It's part of the conversation, right? Anticipate why people might have distrust, like say in minority communities about vaccination. You should pre-bunk the legitimate existing concerns due to issues like Tuskegee, Henrietta Lacks, just overall disparities and kind of social terms of the health. Those are real things that probably should be addressed before you're saying, no, now really trust us. Now we're not, trying to, just not disclose everything that's relevant. And so I think having these conversations is important, because I think, as both Stacie and Greg appropriately said, you need the government to have that flexibility during times of emergency. They can't anticipate everything that needs to be done. And that requires, some trust from the public. But to ensure that trust, they also, I agree with everything Ani and Stacie said, you need that transparency kind of built into the system.
I'm going to add also that you really need leaders who believe in what they have decided. And so when you have leaders who are saying one thing but not promoting it visually, and that comes across, you have leaders who say, yes, I support a mask mandate, but then their photo is taken, without them wearing a mask. I won't name a certain county north of the city who, had a school board that is saying we encourage masks, but then won't wear them for their school board meetings, so that children under 12 who are going to get an award couldn't come to the meeting because they didn't feel safe. When we don't have our leadership actually demonstrating that they have faith in the measures that they are expecting people to do, it's really hard to move from asking people to do something to voluntarily having people do something to mandating it, because they're not understanding why there's even a need at that voluntary level when they don't see that the leadership has actually bought into it. So I think it's really critical that that we aren't talking out of both sides of our mouth. If we believe that something is necessary, then we need to be demonstrating it and modeling it. And that needs to start at that voluntary level. And if something needs to be mandated, then you need to be the first people, to be acting in a manner that, is consistent with what we're requiring the rest of the public to do.
Thank you for that. I'll mention too, just as a plug, the University of Georgia College of Public Health holds a seminar for freshman legislators, because a lot of folks who are in politics don't know a whole lot about public health necessarily. So, you know, I think educating folks when they get involved is an important part too. Being able to know what you're speaking on is great. And that's something I'm really proud of, that we get to be a part of. We've got three, oh, sorry.
Oh, just to another plug then for trainings, we actually launched 2 public health emergency law online trainings. One is introductory and one that's really specific to epidemic response. I'll drop the links in the chat and those are free. I agree. We just need people to be educated as early as possible on the importance of these tools.
And I'll second that, Greg. The Public Health Law Academy, the collaboration between CDC and Change Lab Solutions is really fantastic for understanding public health, not just in emergency situation, but also, you know, in many other areas as well. And for understanding legal epidemiology that you've been talking about, how law can be examined in a way that, you know, shows whether or not it has a health impact, and what, you know, level of a health impact. So I think those are really great tools that are available to lay, not just to attorneys, but to students, to faculty, and to others who are just interested in law and policy.
And a really hot off the presses, you know, last week announcement was that Change Lab Solutions had just launched, I think it's 5 just quick shots of public health law. I think they're like 5-minute long videos, and that can be a really great tool for people who don't have a lot of time on their hands.
That's wonderful. Thank you. I'm saving the chat. I don't know if there's a way to get all of this information out. Hopefully people have been able to click links and write things down, but if there's a way for me to share all this information, that's great. We've got 1 more minute. If anyone has any closing remarks, I want to thank all the participants for being here and the speakers especially. This has been fantastic.
Yeah, thank you so much, Megan, and thank you, Stacie, Greg, and Ani, who's teaching her class right now, and to all the audience for the very kind of thoughtful questions and discussion items. Obviously, this is really important to all of us, and it's clear that this is an issue that everyone here takes very seriously. Because just look at the impact of COVID and just reports of the preventable deaths that occurred, you know, during the first year, during the second year. And I think it's really a charge for us to do better and to seek out the tools to know how we can do better. And, you know, I'm glad, you know, the panelists shed a lot of, I think, useful information and pointing people in the right way to like how to answer these questions, to kind of going forward, keep trying to do the most optimal response to kind of stopping this pandemic and other public health challenges that will necessarily arise.
And I'll just re-emphasize that, you know, it's so critical that lawyers are at the table with public health leadership, not just at the, you know, when an emergency arises, but in the daily regular public health activities. It's great to know your lawyer, to have that relationship, to understand, you know, where you're both coming from as far as disciplines ahead of an emergency, a crisis where you have to, you know, jump right in and respond. And so, you know, having a lawyer at the table helps to identify legal issues, to avoid risk, to potentially weigh risk when it might be necessary to take that risk. To say what the law should be done, yeah, I'm sorry, what must be done, what must not be done, or what can be done if there's discretion. And it's just, you know, beneficial to identify those things at the front end before moving forward when it's possible, rather than sort of waiting till there's a legal emergency and having to and battle that on the back end. So I just encourage you to always work with your attorneys and include them as part of the leadership team.
That's wonderful. Thank you. Carmelita has put the link back to the main session in the chat. We've got a break until 11:15, and then Dr. Adams is going to be introducing Life, our spoken word performer. We'll have a reflection by Yvette Daniels, the director of the Georgia Department of Public Health, followed by concluding thoughts from the College of Public Health Dean Marcia Davis. Thank you all so much for being here, and have a wonderful day.
Thank you.
All right, thanks for having me.
Megan.